I'm just gonna wait a little and then.
Yes, exactly.
So I think we can start then. So welcome everyone to the EANS webinar today. This is actually the last webinar of this year, and it's hosted by the EANS vascular section. And we're going to talk about pathologies or vascular pathologies of the spinal cord. Moderating with me together will be Professor Beruma from France. He's a professor of neurosurgery in Dijon. And I myself, I'm Beate Kranovet. I'm a young neurosurgeon in Germany. And we also have three high-profile speakers today, including Professor Cenzato, who is also the chairman of the vascular section of the EANS and the chairman of the neurosurgical department of the Niguarda Hospital in Milano, Italy. And then we have Professor Veit Rode, who is the chairman of the neurosurgical department at the University Hospital in Göttingen, Germany. And we also welcome Dr. Anne Schmidt, who is a consultant neuroradiologist in London at the National Hospital for Neurology and Neurosurgery. So thank you for joining us today and sharing your expertise and your experience with us. And the first speaker will be Professor Cenzato.
Hello. I want, first of all, to thank Silvia Hernandez, that she organized perfectly all these webinars for the vascular session, and also Monsefa for the presentation here and the moderation of this meeting, and all of you for participation. So I will share my screen. Let me see if it works. Do you see it? There is something. Do you see it?
Yep.
Yes,
Yeah.
it's
Okay.
perfect.
So we will talk about spinal arteriovenous malformation. We will talk about some particular cases, and I would like to focus on some aspect that can be mainly trapping of the spinal arteriovenous malformation and the problem of veins. As you know, there are, wait a minute, there are several classifications now. We are talking about particularly of the intramedullary, intradural AVM, the so-called glomus type, or the one that are in the spinal cord and not the AVM, not the dural fistula and not other condition. They can have multiple shunts. They can have a complex venous drainage. They can have multiple nidus. The problem is that they cause a progressive myelopathy as the dural fistula, engorging the venous side, or they still can bleed. As we know, they have a worse natural history. They are worse than the cerebral AVMs. They have a higher annual hemorrhage rate, and they are highly eloquent, so they can give for sure big problems from a neurological point of view. As I told you, I would like to focus on the vein, because vein are the main responsible for the clinical manifestation. They are the goal of treatment, because at the end, as in every AVM or in fistula, at the end you have to occlude the vein, and they are more responsible for the complication we had. This is the clinical manifestation. The cause are venous engorgement and the pressure gradient between arteriovenous, because the vein has a very high pressure, and so as in the dura fistula, the problem is a problem of vascularization of the spinal cord, and as in the dura fistula, at the end, the goal is occluding the vein, interrupting the shunt. Of course, you have to close the vein without causing hemorrhages, thrombosis, and any neurological damage. Most of the AVMs, spinal cord AVM, are on the surface of the spinal cord. The AVMs of the spinal cord are different than the one in the brain, because the vascularization in most of the case come from the surface, and they are pile vessel, and very few of them are embedded in the spinal cord. So in many cases, they are just on the pile surface, and they can be dissected little by little. And as in this case, I will present you, this was an AVM that seems to be ugly. It was a terrible one, it seems to be very ugly, but at the end, it was just on the surface of the spinal cord and dissected in from the pile surface of the spinal cord and occluding some of the vessels. It can be little by little coagulated and dissected and removed. And the difference also is that we are dealing with pile vessels, so they are more robust than the classic medullary feeder that you have in the deep white matter of the brain, and you can coagulate them, and you can cut them, and you can partially, while a brainstem AVM, you have to get it out entirely. Here you can take out a piecemeal, or you can coagulate some vessel, because the situation is much different. Of course, you have to check the spinal cord function, and this is at the end of the intervention, and this is a post-operative show no residual. And this was a patient on the second day post-op. Of course, this patient has a slight worsening, but until you have the functional the bucket potential within the intervention, and you can remain on a safe area. Another way is, this is another case. This was really embedded within the spinal cord with AVM, and as you see here, the AVM was right in the spinal cord and was not on the surface. This was the AVM. There were some vessels that can go from the surface, and there was a big vein going out, and this was the AVM. What we did here was different. We decided not to enter in the spinal cord, but trap the AVM. Clipping all the vessel, feeding the AVM, and then, of course, testing before coagulating. But we used thulium laser. That it was a very nice instrument that coagulate the vessel without bringing in current, and working in a very superficial fashion on the vessel without damaging the spinal cord behind. And this was at the end, and the main goal was to take out I don't know if you see here, to occlude the draining vein. This was the post-op angio. And this was the patient 9 months after surgery. I will show you the same patient, what happened immediately. This is the last result. This is another case. It was an AVM on the anterior side of the spinal cord, and she had several embolization with a progressive deterioration with this AVM, with one feeder coming from the anterior spinal cord and one coming from the left posterior artery. Also here, she received several embolizations, but with a progressive deterioration over time. So also here, we decided to try to reach the AVM, but the idea was to go anteriorly, and as you see, cutting the dentate ligament, you can reach the spinal cord anteriorly. And so we decided to trap this AVM, occlude the feeder and the draining vein without entering in the spinal cord. But as you see here, rotating the AVM, the spinal cord, and of course under control with the evoked potential, you can reach the anterior side of the spinal cord. And this is the post-op intraoperative post-op angio, where you see the spinal cord preserved and no more AVM or a previous draining vein. So here we trapped the AVM, occluding the two feeders and the three going out vein with the preservation of evoked potential, and the patient had this postoperative MRI and this clinical picture. She could move the legs. She already had a problem on the proximal leg before surgery, and it remained almost more or less the same. What's important is she didn't have any sphincter disturbance. I want to point out the importance of laser. Thulium laser is a very nice instrument, which is very delicate, very thin, and you can coagulate the vessel without heating them too much. And this is some picture to show how you can use with a very thin and very delicate instrument to occlude and coagulating the vessel until this. But at the end, I want to, so the vein are the main cause of clinical manifestation. The goal of treatment is to occlude the vein. And now I'm coming to the complication we had due to the vein. This was an ugly AVM of the conus medullaris. And as you see here, you see this huge venous involvement, but the nidus itself was not so big. So we, and at the end, we operate the AVM. We took out the AVM because it was on the surface. But the problem we had here is that she wakes fine with a minimal weakness on the right leg. But over time, the weakness progresses to the left leg, and in a couple of days, she was completely paraplegic. So we interpreted that this ugly and large venous pouch, although the AVM was occluded, the problem was that this large vein then progressively thrombosed, and so we decide to put the patient in heparin, but after 2 days she had a very intense pain in the neck, and then she suddenly died because something bled. And as you see here, this was subarachnoid hemorrhage all over the spinal cord and the brain. We interpret this as a thrombose of the vein, and then something broke due to the heparin. This is the other case I show you, the cervical one. The patient, I would like to show you what happened. You saw the patient easily walking, but in the immediately post-operative, this was before. And then, as you see here, over time, in the following day after surgery, we have this huge and large edema, and we were extremely worried due to the disruption of the venous discharge of this AVM. So we did heparin, mannitol, steroid, and little by little, the situation progresses to a complete resolution. And this was the follow-up MRI. And as you see here, the patient that discharged was this 3 months after was the one in the middle. And the last one, the one I already showed you 2 months after, 9 months after, was perfectly walking around. So these are the patients we have in our casuistic. We operated 29 patients, but 9 of them, so there are almost 38 interventions, received the second surgery because of a residual, because of we had to go back on the intervention because we thought that there was some vessel remaining. This is the distribution. You see dorsal is the more represented. And almost all the patients had some problem on admission. Very few were neurological normally. Many of them has a mild motor or sensory deficit or moderate and sensory deficit, and some of them had severe or more serious problem. But on discharge, it didn't change much. Some, of course, the completely neurological normal were not present. Some of them had still some motor or sensory deficit. The paraplegic was the one that died, that I already showed you. And at the end, this is the outcome. As you see here, before and after there is a slight worsening, as you see, especially there are some patients that has that before were completely normal, after had a mild, but more or less the situation remained almost stable. It means they didn't get a big damage, but at the end, the goal was to stop the progression of the AVM, stop of the progression of the myelopathy and the risk of bleeding. The dorsal are more fragile. Cervical, I don't know why, are better. And dorsal probably because the circulation is the less represented is more fragile. To conclude, the cervical spine AVM has a better favor outcome in our experience. Dorsal has a more aggressive behavior. And in conclusion, I think that spinal cord AVM has a very bad natural history, and we all know it. And we need a multidisciplinary approach. We have to interact with our endovascular team. But when you cannot take it out, I think that trapping can be an option. And of course, monitoring and neurophysiological monitoring is absolutely fundamental. We had some residual. We went back on the residual over time, so probably could be we can plan a staged resection and not necessarily take out all in the same in the same session. And I want to focus the attention on the venous side. Thank you.
Thank you, Professor Censato, for this very nice and honest presentation on this difficult disease. We can keep the questions at the end of the session, maybe, because it's all about spinal vascular diseases. So we can move to, we have the pleasure to receive Professor Rode from the University of Göttingen, who will share his large experience on spinal dural AVF. Please, Professor Rode.
Yes, first of all, thank you for inviting me for giving this lecture. I just share my slides. So it's a pleasure for me to say something about spinal dural AVFs, which are one of the diseases I'm following now for more than 30 years. As you might know, it was being mistaken for a long time as not a vascular disease, but an inflammatory disease. And one of the old names was the Foix-Allain-Joannin syndrome, which you still can see in the textbooks. But in fact, it's not an inflammatory disease, it's a vascular disease in which we do have a connection between radiculomeningeal artery, a dural fistula point, and at this fistula point, there is a connection to a perimedullary vein, which normally drains the spinal cord. This pathomechanism had been investigated very closely with microdoppler in the end of the 1980s by Mr. Hassler, who was my first chief. And you can see that the connection between the radiculomeningeal artery and the vein means that you have an arterialized vein, that we have a high pressure in the vein, and this is leading to the typical symptoms of the dural AV fistula, which is related to an edema or a venous congestion in the spinal cord, as you can see it on the T2 images. The symptoms of spinal dural AV fistulas at the very beginning are quite vague. The patients complain about some walking disturbances, sensory disturbances, some sort of paresthesia, low back pain, pain in the legs. So if you read this, especially the symptoms on the left side, you see that many of these symptoms are very, very similar to those of degenerative diseases of the spinal cord. And this explains why the delay between the first symptoms and the diagnosis is quite large. These are our patients. We have now more than 100 patients, but we make the evaluation concerning the symptoms after almost 80 patients, and most of them complain about some sensory motor deficits. Very few presented either with acute or subacute symptoms, but in most of the patients, it was a chronic disease with symptoms which were becoming worse and worse over the years. Almost 80% complain about sphincter disorders, and you can see that in our series, the delay between first symptom onset and the diagnosis was almost 18 months. And as you know, mostly elderly men are affected by spinal dural AV fistulas. If you have the suspicion of a spinal dural AV fistula, I think the very first diagnostic, as it is in many other diseases now, is to perform an MRI. And on the MRI, you see typically enlarged vessels on the dorsal part, mostly dorsal part of the spinal cord surface. And if you're giving gadolinium, you also see an enhancement of these vessels. These vessels on the spinal cord are the arterialized veins which are the effect of the connection to the artery, the radiculomeningeal artery. And also very typical, I already have shown it to you, is the T2 hyperintensity, which is which is a sign for edema or the venous congestion. And these symptoms are, or these signs in MRI are visible in almost 100%. So if you have a suspicion of a spinal dural AV fistula and you don't see any vessels, and if you don't see any edema, the chance that the patient has a spinal vascular disease is very, very low. Today, still, we have to perform an angiography to really show that we are dealing with spinal dural AV fistula. And typically, you see the fistula point in this area. This is the artery. Here is the fistula point at the dura, and this is the arterialized vein, which is on the surface of the spinal cord. You also have to perform angiography to rule out rarer vascular spinal diseases such as AVM, as Marco just has shown you, or also the perimedullary fistula. So still today, angiography is necessary to diagnose spinal dural AV fistulas. Interestingly, I've never seen any spinal dural AV fistulas at cervical levels. Sometimes you have draining veins. If you have a dural AV fistula at the craniocervical junction, which belong to the cranial AV fistulas, and most fistulas are in the thoracic segments, and very few are at the lumbar segments, and sacral dural AV fistulas do exist. They are very hard to diagnose, but they're also very rare. If you have seen a patient with a spinal dural AV fistula, we have to consider what to do with this patient, if we should treat a patient or not. There's one very, very old study, a study which today never would have been performed again. They look for the natural history of spinal dural AV fistulas, and they've shown that this disease is always progressive, and it results in invalidity within 5 years, which means that you have to treat the patient if he is symptomatic. And as always with vascular diseases, we have two options. We have embolization and we have surgery. What about embolization, which today is very popular? I'm not a neuro interventionalist, so these are data which have given to me. So if you're performing the treatment of a patient with a spinal dural AV fistula, you have to position the embolisate directly at the very, very first part of the arterialized vein, which is at the level of the very first level of the intradural segment. And it seems that doing this is not so easy. There are several studies dealing with the occlusion rate of embolization. This is an older study from 2004. It's a meta-analysis, and in this meta-analysis, the occlusion rate was less than 50% over the years. Obviously, these bad figures improved, but they are far from being good. These are newer studies with a 60% occlusion rate, and redo at 37%. And one of the best results is given in this study, in which they have been able to occlude 77% of their 78 patients. It's also not a matter of the material you're using for the embolization. If you're looking at the morbidity of embolization, there are also a few studies, and I think very important is that even a complication is occurring, then the complication is severe, because this complication mostly is a spinal infarction, which is always related with neurological deficits. And this had been outweighed against the alternative of surgery. If we are looking for surgery, I think we can do it today quite minimal invasive. So in my department, we are performing upper partial hemiluminectomy. You just open the dura a bit out of the midline in the area, in the region of the radix. You identify the very first segment of the arterialized vein, which is in this area. Here's the dura, here is the arterialized vein, and then you can simply coagulate and cut the vessel, and the disease is done. I mostly use microdoppler in these cases, because then I can perform sonography on the vessels on the surface of the spinal cord, and if I can see that there's no flow, I know that I coagulate the correct vessel. You also can use ICG angiography, but it's nice to have, but it's not mandatory for performing this operation. And if you're dealing with a dural AV fistula, which is not related to the artery of Adamkiewicz, you can do spinal cord monitoring, but it's not absolutely necessary because the risk of neurologic deficit is very low. What's happening with the symptoms if you're performing operation? So the symptoms immediately after surgery, so within 3 months, you have an improvement rate of 67%, 22% remain unchanged, and you have a worsening in 11% in the early post-op period, which possibly is due to the thrombosis of the arterialized veins. And this is a reason why we're using heparin for 7 days, 15,000 units per day, just to slow the process of the thrombosis of the arterialized veins. If you're looking into the longer follow-up, you see that the improvement rate is going up, and the rate of patients with neuroworsening is becoming lower and lower. This is in the early period. If you're following the patient over years, then you see that the improvement rate is dropping again, and the rate of neuroworsening is going up again. And this is probably due to the progressive spinal cord atrophy, which you can see in many spinal cord diseases, not especially in spinal dural AV fistulas, but in other diseases also, and which is a situation in which you cannot help the patient. This is the bad natural course if this is happening. So this is one of the examples for this. You see the pre-op symptoms, you see the post-op symptoms, but the post-op MRIs, you see that the vessels and the edema on the surface are gone. And the patient came back quite early after 1 year, and he complained about symptoms again. We performed an MRI. We didn't see any vessels, which proved that there's no recurrence of the fistula, but we see atrophy of the spinal cord, which probably was the reason for the secondary neuroworsening. Complications are rare, and they are not related to neurological deficit, as you can see it here in our series. What about the occlusion rate? We also have good data on this. Steinmetz not only performed a meta-analysis on the results and on embolization, but also on surgery. And in 2004, he had an occlusion rate seen of 90–80%. And this is exactly that what we have seen in our own series here we have looked at 87 patients, but in more than 100 patients. So my conclusion for the spinal dura AV fistulas, if you have a patient with a spinal dura AV fistula, I think we should proceed to surgery because of the high occlusion rate and the morbidity rate, which is quite low in comparison with embolization. The occlusion rates are much higher and the complications are less severe, which means for me that surgery should be the first line treatment in patients with spinal dura AV fistulas. Thank you.
Yeah, well, thank you, Professor Rode. I think we're going to keep those questions for the end of the session. And we're going to continue with Dr. Anne Schmidt from London, now the interventionalist side.
Can you see my screen? Can you see my screen?
Yep.
Okay, so hi, yeah, thank you very much for the invitation. I wasn't aware of the series. I'm quite excited to be part of it. So yeah, I work in London. I work at the National Hospital for Neurology and Neurosurgery and at the pediatric hospital next door, which is Great Ormond Street. I think most of it that's in my talk, we probably have touched base on in the last two talks already, but I'll just try to fill in the gaps and give you a bit of a perspective from an INR point of view. So what I was planning on covering is the essential anatomy, classifications of AV malformations, which you can probably skip, and then looking at treatments and at a few cases. So essential anatomy, we've just discussed it already. You got the ASA, which is a single vessel anterior to your spinal cord. Posterior spinal arteries are paired. They receive contributions at segmental levels. The largest one of those is usually located within your mid to low thoracic spine, and that's the artery of Adamkiewicz. Classification schemes, there's loads of them around. There's a bit of a running joke in INR that there's more classification schemes than pathologies. I think the most commonly used one now is Spätzle, or a mixture of Spätzle and Ticiro maybe. The spinal fistulas are the most common ones, spinal malformations, around 20 to 30% of spinal vascular pathologies, and then there's some which are much, much rarer, so PL fistulas or intra and extramedullary spinal AV malformations. I found this classification or algorithm quite useful. That's been published by Krings, where you basically look at whether there is a shunt present. If there isn't, then it's a cavernoma pretty much certainly. If there is a shunt present, then you need to look at which artery is supplying it. So if it's one of the meningeal arteries, it would be a dural AV shunt. If it's one of the intraspinal vessels, then it would be a fistula or an AVM. If it does have the pathology, if it does have a nidus, it's a glomerular AVM. If it's a single point or multiple point fistula, it would be a micro or macro fistula. One thing that we maybe haven't mentioned is that macrofistula are usually associated with some sort of genetic pathology. So you might have a RASA1 mutation, or you might have a HHT or a Klippel-Trenaunay-Weber syndrome. Going through the imaging, that's probably what you would like myself to contribute to. So how we image our patient, I think it's accepted that the gold standard for assessment of the spinal cord is an MRI. I would like to see a higher field strength. So if you image your patients at 1.5 Tesla or ideally at 3 Tesla, you have a high signal ratio and a high spatial resolution and a high signal to noise ratio. As a minimum, what we do a sagittal and axial T1 and a T2, and also a stir, which is quite useful because it suppresses fat signal. It allows you to assess the intrinsic architecture of a spinal cord better. So if there's any spinal cord lesions, if there's any edema, if there's any infarcts, you would be able to see them better than on a normal T2 and T1. Another thing that's quite useful, that's gradient GRE, so T2 GRE, which again is also more useful in assessing the spinal cord, but it does overestimate spinal canal stenosis. So we wouldn't usually do that on itself. You always need it in combination with another T2 sequence. DWI to assess for cord ischemia seems to be also something that centers do. We don't usually do it because as a department, we don't think it adds much information. Post-gadolinium, as it has been mentioned earlier, is very useful in the assessment of dural fistulas, or also indeed of spinal arteriovenous malformation. And there has been a paper published by the Toronto group which states, or which showed, that a dural arteriovenous fistula on a contrast MRI can be picked up in 80% and other spinal arteriovenous malformation in 60%. So post-contrast MRA is very useful in picking up whether there is a fistula or not. But then you could also do a dynamic sequence, so a dynamic MRA, which is a twist or tricks on our scanners, which would allow you to localize the fistula even better. So there has been a paper around, I think I got it here, by Namani, which showed that in 47% a dural AV fistula can be located through a dynamic MRA, and in 90% of cases it can be located ±1 level. So it's pretty good. CT-CTA doesn't have much of a role in fistula assessment. I think the gold standard, which we come to later, is still a DSA. It sometimes adds some information if maybe a spinal fistula hasn't been identified on a DSA and you just want another check, rather than doing a repeat DSA. If the suspicion is low, you might want to do a high volume contrast CTA just to check whether there's any small shunt evident. That's a patient that we've met fairly recently, probably around 6 months ago. He was a referral from Cardiff, professional skateboarder, who presented with 6 weeks off legs, a little bit of weakness, and was developing bowel and bladder symptoms. So the MRI shows quite extensive cord white matter changes and displacement of the cord anteriorly. The signal goes up, normal signal goes up to mid-thoracic level. And what we then did, we did a twist, so dynamic MRI sequence, which shows on the far right side that you have some early venous filling, probably from a mid-thoracic level. So now we know that the patient most likely has some sort of vascular pathology in the spine, and we got all the information that is possible from MRI and dynamic sequences. So then the gold standard to assess the vascular lesion is still a spinal angiogram. Traditionally, we used to do them, we still do them under GA, but traditionally we used to do them under GA and inject every segmental level bilaterally, which you can imagine is quite a lengthy, or can be quite a lengthy procedure. But what we do now that we know that the shunt is potentially in the mid-thoracic region, we can target the angiogram much better. We use a spinal angiogram for diagnosis, but mainly for characterization and to have a good look at the angio architecture, and then also obviously for treatment planning, because it's useful for us, but more so for the surgeons as well, because most of these pathologies are probably treated surgically. What we use, I'll use, as a patient will be asleep, a 5 French sheath. There's different catheter that we can use, so I prefer the Cobra catheter, which is on the top left row, or a Simmons catheter, which is in the bottom middle. And then we just have to select the segmental arteries. Sometimes if it's a high cervical or low intracranial one, we would do the cervical and cerebral vessels, and also very important for low-seated venous vascular pathologies, to inject the lateral and median sacral arteries as well, because it's not infrequent that you see a shunt contribution from these arteries. So yeah, as I said, we can now target DSAs more. What also is very important, so also to find the pathology, but to exclude Adamkiewicz. So once we've identified the dural AVF or the AVM, we also need to check that there isn't any significant spinal cord supply at the level, or the level above or below. Once we've excluded Adamkiewicz, I think we can be happy with that. Another technique that we use for DSA or other imaging modalities that we could use a 3D spin. We can also often do microcatheter angiograms, which allow us to select the segmental arteries a bit better, maybe take our microcatheter a little bit further just to assess the angioarchitecture in more detail. And there is a limited role, I think, at the moment for 4D angiographies. That's more important for intracranial AVM. That's where you attach a temporal resolution component to your 3D angiography, and vasal CT, which is basically a CT thin slices that is done on the angio table. So that's just some images from the same patient. I think it was located around, if I remember rightly, T8 or T7 on the left. You can see the segmental arterial supply. There's a very thin, which might be difficult to appreciate, very thin ASA supply going upwards, and then a descending hypertrophied branch going downwards. Within the tangle of the orange, that's a 3D angiography. So when you see it on the console, it allows you to rotate the images around. There were a few perinidal or intranidal aneurysms, and on the MRI imaging, it looked like there was some edema, particularly around there. The one on this right-hand side, that's a vascular CT, where you basically have the enhancement, but also the bony correlation, which can be quite useful for treatment planning. That's a patient with who presented to us, I think probably 2 or 3 years ago, with a very, very long-standing history of progressive symptoms. It's a typical symptoms for a dural arteriovenous fistula. He does have quite significant cord edema. He was a patient who was rather unwell. He was very obese and he had multiple comorbidities. So that's his imaging. On the left-hand side, you see a twist again, so a dynamic MRA, which shows that there is early venous filling contributed by some segmental artery in the mid to high thoracic region. On the left, on the middle screen, you can see left segmental arterial supply to an arteriovenous fistula, and it's quite a network with then very dilated veins that go cranially and caudally. And there was minimal supply from left T9. So yeah, we went through this. What we've learned already, there are high recurrence rates for endovascular treatment. I found another study from Bakker et al., a meta-analysis from 2015, which basically said you get 97% occlusion with surgical treatment, 70% complete occlusion with endovascular, but there is quite a high OR for endovascular recurrence, so a 3.15 odds ratio that it is more likely to have late recurrence with endovascular treatment. And also what's recently been demonstrated, that there is a higher recurrence with onyx versus glue. The key is always when you treat a dural arteriovenous fistula to reach the vein, because it is a venous pathology. But I think the higher recurrence rate with onyx stems from the fact that onyx is non-thrombogenic versus glue, which is actually fairly thrombogenic and probably promotes the healing process much more. That's a new study from March 2024, which again shows the same thing. It's not significant, but I think it's another support for surgical treatment rather endovascular treatment. Going back to the embolic materials, so what do we use? There's 2 different types of materials. The top 2 are different glues. So you have glubran and histocryl. Glubran, both glues you need to mix with some sort of radiopaque material, which is either tantalum, it's kind of like a black powder substance, or lipidol, which is an oily liquid. We use lipidol also to dilute the glue, because you want to target your percentage glue mixture depending on how thick you want it. That would be, the glue would be delivered through a magic microcatheter, which is indeed very, very small. For AVMs, it's very important that you have the catheter in a wedged position in the sulcocommissural arteries, because you can't really afford any reflux into the ASA. And then a technique which I've used a few times and has been published before is it's more relevant for dural arteriovenous fistulas. It's a D5 dextrose push. So glue on contact with blood is thrombogenic. Also, before injecting glue, you always have to flush your catheter with dextrose, because if you also in contact with saline, it would be thrombogenic. So what you can do once you have your microcatheter in an appropriate position at the fistula, just to promote further travel of the glue, you could attach a 50 or 60 ml dextrose syringe, so 5% dextrose, to your guide catheter, and flush the guide catheter. Get your assistant to flush the guide catheter whilst you inject the glue. And I have a case of that in a little bit. Less of a role in spinal treatment is onyx and squid. Squid is similar to onyx. They're liquid embolic agents, EVOH. They're solved in DMSO, or dissolved in DMSO, and the radiopacity comes from tantalum powder. Newer agents are fill, which is less black, because it doesn't have, or the tantalum powder is slightly different material. And the obtura, which is quite an exciting new development and probably has more a role in serial intracranial AVM treatments. There has been one trial. It's basically a liquid embolic material, performs similar to onyx or squid, or indeed fill, but it does lose the radiopacity. And how can that happen? They obviously keep that quite a secret, but it's rather than tantalum powder, which is the radiopaque component, it is iodine, and that is degrading. So after 30 days, they claim that 90% of the iodine has degraded, which is quite useful because it wouldn't cause any artifact when imaging the patient afterwards, and when doing another embolization, it wouldn't obscure your view. I think when talking about embolic material in spinal vascular treatment, it's always quite a bit of a balance between penetrations into the target vessels, reflux, and thrombogenicity. So you do not want any reflux. You want ideally a lot of penetration, which you get much better with onyx and squid and these liquid embolic agents. Reflux is higher for these liquid embolic agents, but thrombogenicity is better with glue. So I think a summary from that slice, glue is probably better for spinal embolization because it is more thrombogen and you have less reflux and you can just target it a bit better. So treatment at Queen Square, I think I've kind of probably implied that surgical clipping for the majority of the dural AVF cases, especially cervical, thoracic, and upper lumbar. There might be a role for endovascular embolization in low lumbar cases or in sacral cases, where you don't really need to be scared of ASA or PSA supply. How can we help the surgeons? So what we often do for our patients that go for surgery, we would mark the vessel or mark the fistula's point, usually on the contralateral side, or maybe in the intercostal artery on the same side, because if you attach a coil in the segmental artery, you might deflate the fistula, which then makes it for the surgeon much more difficult. What else? So yeah, another reason why I think endovascular embolization has less of a role in high cervicals or cervical thoracic upper lumbar fistulas is that I've seen quite a few cases, or not quite a few, 2 cases, where spinal cord supply was not visible on the initial DSA, but then once the fistula had treated and you do a check angiogram at that level, you could identify a very small ASA or PSA supply. So I think sometimes they are very, very difficult to see, but could theoretically cause massive complications if you inject at that level. Another paper that I found quite interesting when it comes to an INR point of view is the one that is here at the bottom, factors determining the success of endovascular treatments amongst patients with spinal dural AV fistulas. And that's a little bit common sense. So at the bottom, you have a fistula which goes through a fairly tortuous network, whereas in picture A, you have a fairly straight lead up to the fistula with a straight vein. So getting good penetration into the venous component in A is much easier than in C. So sometimes the success of an endovascular procedure depends on the angioarchitecture. So that should also be considered. That's a case that I treated. That's a rare case where the patient had a mid-thoracic fistula. That was the patient we saw earlier, the one that had multiple comorbidities and was very obese. So not the ideal surgical candidate. The anaesthetists were very nervous about proning him for spinal surgery. So what I did embolization of the dural AV fistula at the T7 level, which usually, most likely, probably would have been a surgical target. It's quite a torturous course up to the fistula's point. I'm not sure whether I made it easier with all those colorful arrows down there, but the red arrow at the top picture, you can see that that's my microcatheter. The hook is the guide catheter. And that's the patient where I used the glucose push technique. So I got a little bit of glue. I think it was a 60% glubrand solution forward. A little bit into a vessel. It must have been an intercostal artery that was leading laterally. And then we started injecting the dextrose, which then gave us actually much better penetration into the venous network. And that's the final image. Might be difficult to see, but you can see some embolic material or glue around the spinous process at that level. So yeah, we also discussed that in the past. A natural history of spinal cord AVMs is quite grim. Annual risk for hemorrhage 4%, and if a patient has bled already, 10%. So yeah, I think we pretty much covered that. So I think discussing the treatment of these pathologies is much more complex and less clear. How do we treat them? It's usually a multidisciplinary approach, case-by-case basis. It depends on how risky we think it is to access them and what the benefits are. If it's surgically accessible, I think the surgeons usually get first dip, but we have quite a few patients due to the pediatric connections which have a Klippel-Trenaunay-Weber syndrome, where you treat them more reactively rather than with a curative approach. What seems to be a common thing that we do now at the moment is we target high-risk features and bleeding points. How we would do that, again, with coils, with glue. So you need to get a wedge position into the sulcocommissural arteries, and then also coiling of intra or perineal aneurysms. And that's the skateboarder that we discussed earlier. He had a fairly, what looked like high flow lesion with a lot of prominent veins and a few intranidal aneurysms. So far he's had 2 treatments where we just try to take the heat out of the lesion by keeping the ASA open. So far he's done quite well. That's a follow-up MRI. That was just a month after the procedure, the last procedure. So his cord edema has gone down, and he's due another follow-up. That's a patient that I met in clinic last week, a young student, fresh year, studying rugby, which he's now stopped. And a year ago, he presented with sudden onset headache, ataxia, nystagmus, and he also dropped his GCS down to 12. It turned out he had bled from this high cervical arteriovenous malformation. Unfortunately, I don't have the best pictures, but this is what we're faced with now. So that's his angiogram. There's bilateral vertebral supply with intracranial and also drainage along the spinal cord. And then there is this small aneurysm, which probably, by the looks of it and analyzing the cross-sectional imaging and the angiography, is the bleeding point of the lesion. So that seems to be our next challenge.
Yeah, so thank you very much. There aren't any questions in the chat, or actually only one, but I actually have one question to the endovascular treatment. So differently from the cranial AVMs, there has been reported in the literature that partial treatment of spinal AVM leads to a hemorrhage risk. Do you have any experience with that, or
Sorry, say that again.
usually? Yeah, so in intracranial AVMs, it has been reported that a partial treatment, especially with endovascular methods, can lead to a higher risk of, and it appears now that with the spinal AVMs, it doesn't seem that way. Do you have any experience with it, or?
Whether there's any, I'm not sure whether there's any much evidence out on that. I can see how that applies to intracranial AVMs because you totally change hemodynamics. I don't have much experience with that in a sense of whenever we do partial treatments, we do it in cases where we can't offer curative treatment. It would be reactive mainly in those patients who have most likely have a syndrome like a Klippel-Trenaunay-Weber or so, where we then treat small bleeding points that we think or small high-risk features. So far, we've made things better. I haven't had a patient where I had the feeling that they then have bled because of the treatment. But I think there's just not enough evidence because the lesions are unfortunately very, very rare.
But could I have a remark?
Of course.
There's a study or a meta-analysis from Gross and co-workers. It's quite old now, I think more than 10 years. And they showed that with spinal AVMs, if they're partially embolized, you don't change or even you lower the rebleed rate, and you're resulting in improvement of the patients, probably because you change the hemodynamics, which mean that the veins, the draining veins, are not arterialized as severe as it was. So partial embolization makes sense, as do partial surgery in spinal AVMs, which is completely different to brain AVMs.
Perfect.
May I say also, we see several AVM that had spinal cord AVM that had over time several embolization. The goal of that was to reduce the venous charge and the venous load, but they improve for some time, but then little by little the history is still going down. For this reason, we had some patient that after several embolization, or also it happened to me to operate people with the 5, 6, 7 session over time over the year, and then at the end we decided to operate them.
Why did they not initially go for surgical treatment? Was it too complex of a lesion or patient choice?
Yeah, no, yeah. Well, they were not treated here also. They were treated elsewhere. But also here, in the beginning, we were reluctant. Then once we started to do it, and we saw that it was feasible, now we are much more prone to operate them.
Yeah, I think that's probably the thing with a lot of different pathologies. It ultimately comes down to experience, and yeah.
So there's one more question for Professor Censata in the chat regarding the postoperative management of AVMs. Do all your patients receive heparin and mannitol, or how do you decide which patient will receive it?
Yeah. Well, as I show you, when you have a large venous involvement, we are afraid about that. And so when you have a large thrombose, we try to put heparin as soon as possible, but also putting heparin in immediately post surgery is not so easy also. So we do a compromise. Normally we put low molecular those low molecular weight heparin in the first day. We do 5,000 the first day, and then increase in the second or third day to 4,000 for 1 week. But we had also a patient that was another patient we had a patient that was kept on heparin for 1 month, and then he went to rehabilitation, and then after 1 month they abruptly suspended heparin, and he became in a few hours completely paraplegic. So it was something that was he was kept in heparin for 1 month, and then still there was a problem due to the vein that suspending the heparin. He had a problem, and there was nothing to do. So it's a different big balance, but I think that we, as I hope I will stress it, I think that the veins are still a big problem.
Just reading if there are any more questions. I think we answered them all. Do the speakers have any questions or want to discuss anything else, or otherwise we can?
No, I would like to point out also, if I can support the surgical choice for AV fistula. The problem, I think, is that within the vascular, sometimes it seems to be treated, and I have seen a few cases that has been treated endovascular, but then the recurrence was shown after 1 year of deterioration. So the risk in treating them endovascularly is for AV fistula is that you lose time again, because if as you know, the time in that kind of pathology time is not brain, is spine, because when you have a venous hypertension, then the problem is ischemic sufferance of the spinal cord. So if you embolize, it seems to be fine, then go home, and then the process is still going on, and then you recover, you understand it 1 month, 1 year later, still you have a progressive of the disease. So for this reason, probably endovascular also is, if it fails, is worse than surgery, I guess.
Yeah, I would agree with that. And I think the fistula always seems to be directly under the pedicle. So for the surgeons, it seems to be a fairly easy procedure.
Yeah, from a surgical point of view, yes.
So why go for the more complex, more risky? Not saying that there isn't a role for INR, but I think for cases where there isn't a surgical option.
I've had several times the discussion with neuro interventionalists at the ASMED and at other occasions. For me, it does not make sense, because if you have a highly effective therapy in terms of occlusion rate, with a lower, let's say, severe morbidity rate, then how to explain to the patient that you would like to do something else, which has a higher complication rate and a low occlusion rate, and the risk of being retreated and the risk of a recurrence, which, as far as I know, very barely happened in surgery. And as Marco already said, the time until recurrence, and then the time to diagnosis is already a time in which the spinal cord is harmed again by the edema. So this makes for me no sense. And if a patient wishes it, it's okay. But I think a patient should be advised that you have two treatment options with an inferior and a superior option, and then the patient has to decide. But I think you cannot say that the options are equal.
No, they're not. And I think the case that I showed with the very comorbid or multimorbid patient,
Yeah,
I think there's a role for that, but not as a first line. I agree with that.
So there are two short questions I think that we could answer. So one person asked if there is any role of radiosurgery in spinal AVF or AVM. So I think, is anyone who wants to answer that? Or?
Yeah, so I do, if I may. So we have a gamma knife center at Queen Square, the gamma knife MDTs as well. We've taken, for example, this patient with a spinal cord AVM, the last case that I've shown through the meeting, but it's a very eloquent lesion. There might be a role for AVMs, but you have very eloquent tissue around it. It's not an immediate treatment. It takes 4 years to work. For fistulas, there's not a lot of evidence. They're probably too high flow to work. And again, it's a very eloquent.
Yeah, and there are a few small series with spinal AVMs, and the results really have been very, very poor, with a very low occlude rate of 5 or 10%. And I think there's absolutely no role for the spinal dura AV fistulas.
Yeah.
We do have a gamma knife, and we don't use gamma knife for spinal cord AVM.
So there's one more question. I think we are. So should asymptomatic fistulas be treated or followed up? Do you have any recommendations on that? And how high is the risk to develop severe?
Dura AV fistula.
Yeah, fistulas. Yeah.
Well, with dura AV fistulas, if the patient is completely asymptomatic and there's no edema in the spinal cord, for me, it's difficult to convince him to be operated, but I would follow him closely, because at least the old study says that at one point the patient will become symptomatic. I wouldn't try to convince him, but I would to have him on a close follow-up.
Yeah, I agree. I think because the progression is always in 3 years, most of the patient will need a wheelchair. So it's better to get it before symptoms. So if I would present him to be lucky, because we discovered it before his fistula damaged his spinal cord. But I will try to force him to suggest him surgery strongly. No, like, what do you think?
Yes, I have the same impression. For me, it's just I don't want to I would like to give patient the data from the literature, just to show what he could expect, but I don't want to push him too hard if he is asymptomatic. That's so it's yeah, so in between part, I would say.
Okay, then one more question is, do sacral or low lumbar fistulas also present with cord swelling? Do you have any?
Yeah, they do. They do, because they start sacrally, but the draining vein might run up to the spinal cord, at least the lower part, and then it causes also edema and symptoms.
Then I think we can close this webinar if there are no other questions or remarks. Thank you very much for your time and sharing your expertise with us. And
thank you.
have a good night, I guess, or evening. Yeah. Okay, thank you.
Well,
Happy
have a nice
Christmas
Christmas
and
also.
New Year.
Merry Christmas also.
Yeah.
Yes, Merry Christmas and a happy New Year. Thank you. Bye.
Bye.
Okay, bye-bye.